To perform a complete, independent bedside cardiac ultrasound, you must capture the human heart from 5 specific windows. Step 1 is your physical setup. Lay your patient flat in a supine position. Select a phased array probe and set your machine to the cardiac preset. This diagram compares a standard ultrasound interface to a cardiac layout. Notice the orientation marker. In almost every other bedside scan, the marker sits on the left. In the cardiac preset, it is strictly on the right side of your screen. You must respect this orientation flip. If you hold the probe backward, you will reverse the left and right sides of the heart on your monitor, leading to a completely inaccurate clinical assessment. Your first window is the Parasternal long axis, or PSLA. Place the probe at the 4th intercostal space, right next to the sternum, and point the indicator toward the patient's right shoulder. This simulation shows the cross-section, the right ventricle at the top, then the left ventricle, left atrium, and finally the aorta. If you lose orientation, remember the 3 L's. In the parasternal long axis, the left ventricle is on the left side. To transition to the parasternal short axis, keep the probe in the exact same spot on the chest, but rotate it 90 degrees clockwise so the indicator points to the patient's left shoulder. This is the mid-papillary level. You are looking at a cross-section of the left ventricle, which forms a thick, muscular donut shape with 2 papillary muscles protruding into the center. To view the next level, simply tilt the face of the probe up toward the base of the heart. This brings the anterior and posterior leaflets of the mitral valve into view. Because of the distinct opening and closing motion, sonographers call this the fishmouth view. Slide your angle one more time by tilting the tail of your probe downward, aiming inferiorly. Now you are at the aortic valve level. The 3 distinct leaflets of the aortic valve form a Y shape, widely recognized as the Mercedes-Benz sign. By viewing the heart in its long axis and then slicing through it in the short axis, you gather a complete 3-dimensional assessment of how well the left ventricle pumps blood, all from a single intercostal space. Next is the apical 4-chamber view. Move your probe down to the point of maximal impulse, typically just under the left breast. Point the indicator to the patient's left side and tilt the tail of your probe down toward the bed. This diagram outlines the resulting layout on your screen. You have a direct side-by-side view of the left ventricle, left atrium, and right atrium. If air in the lungs obscures your image, roll the patient onto their left side. This left lateral decubitus position physically drops the heart away from the sternum and closer to your probe. If a 5th chamber appears, tilt the probe tail slightly toward the patient's head. Tilt too far and you hit the coronary sinus artifact, mimicking an atrial hole. Correct this by dropping the tail toward the feet, returning to a true 4-chamber slice. Mastering these millimeter-scale adjustments ensures you are looking at true anatomical structures, preventing you from diagnosing a septal defect that does not actually exist. The 4th window is the subxiphoid view. Have your patient bend their knees to relax their abdomen. Switch to an overhand grip. Place the probe under the xiphoid process and press down gently so the probe lies parallel to the skin. This simulation shows why we use this angle. The dense tissue of the liver acts as an acoustic window, allowing us to see the heart chambers below while bypassing the gas in the stomach entirely. Keep the right atrium in view and rotate the probe 90 degrees clockwise so the indicator points toward the feet. This brings the inferior vena cava into a long axis view. Have the patient take a deep sniff and watch the IVC walls physically collapse inward. Measuring the diameter and collapse of the IVC provides a direct, real-time estimate of the patient's central venous pressure. If the vessel collapses easily, the pressure is low, meaning the patient can safely tolerate intravenous fluids. You have now successfully navigated all 5 of the standard anatomical windows required to complete a comprehensive bedside cardiac ultrasound. With these specific views secured, you can accurately calculate a reduced ejection fraction, or identify fluid accumulating in a pericardial effusion, or spot the enlarged right ventricle that signals right heart strain. To get consistent images under pressure, practice these exact probe placements on healthy models until your hands memorize the correct angles. Internalizing these physical movements lets you bypass the technical setup and focus strictly on the anatomy. Once the motions become automatic, you turn an imaging device into a definitive diagnostic tool right at the bedside.